Hi, my name is Olvera, and I'm the educator for high-risk maternity and labor and delivery, and I want to say happy Sepsis Awareness Month. This time we're going to actually be talking about antibiotics, and the reason is because antibiotics are actually the most crucial intervention that you can do for somebody that is septic. It actually shows the mortality rate within the first hour. If you do not start that broad-spectrum antibiotic, that their mortality rate doubles for each hour of delay. So it's really important to get that antibiotic on board. Common organisms for our OB patient is E. coli, gram-negative rods, and group A strep. Group A strep is for those patients where they go into necrotizing fasciitis. The mortality rate is very high. But the important thing to know is group A strep is treatable when they're on the right antibiotic. Antibiotics are selected according to the source of infection, and so that's why I decided that it was really important to talk about antibiotics, because you have to be on the right antibiotics in order for the patient to get better. So we're going to talk a little bit about that. Source control is always a priority. If you have a patient who has continued fever, you have them on antibiotics, they can't figure out what the reason is, always think source control. Think maybe they have an abscess, maybe they have something inside that needs to be removed. So source control is always at the top of our minds. And for unknown source, if we just don't know what it is, we have an antibiotic selection for unknown source. And then we always want to get blood cultures, because blood cultures are actually really important to identify the bacteria. And then once the results come back, we know the bacteria, we can actually put the patient on the appropriate antibiotics for that bacteria and start de-escalating, which means start decreasing the amount of antibiotics the patient is on. So a little bit about, we're going to start out with intramniotic infection, and AMP and JET is actually the best antibiotics for a patient who we think may have chorio. And so we do AMP and JET, and then if they go for a cesarean section, we add the clindamycin. So in the recovery room, ask for the clindamycin if it hasn't already been ordered for a patient who is now sepsis screen positive. Allergies to penicillin, that's always a frequent question. Ideally, is to have the AMP, JET, and clinda, but if they have a penicillin allergy, they can be on the clinda and gentamicin. Some providers will choose to do cefoxitin, and it's a great cephalosporin. It's a 4th generation cephalosporin. It covers a lot of different bacteria, but the one thing it doesn't is group B strep. And group B strep is, as you know, prevalent in our area. And we even had a case where the patient was GBS negative at 36 weeks, but came in and was very sick and went up to the ICU because she had group B strep, and she was taken to the ICU. So cefoxitin was not the appropriate drug. So always think if they're on cefoxitin, be thinking maybe to add another antibiotic, and you can go through pharmacy or through your physician or RRT. So I like to talk a little bit about penicillin allergy. And cephalosporin can be, when we have a patient who has a minor penicillin allergy, it's not anaphylaxis, that we can actually consider placing the patient on a cephalosporin. But if they have if they have anaphylaxis, penicillin, you cannot give a cephalosporin for somebody with a penicillin allergy. So endometritis, same kind of, I call it cocktail as the intramiotic infection. We do the AMP and JET. We can now dose it with 5 milligrams per kg every 24 hours. We can just give a 24-hour dosing because now we don't have a fetus to consider. AMP and JET is still going to be your antibiotics for vaginal births. You're going to want to add the clindamycin if you have a cesarean birth. For allergies to penicillin or cephalosporin, you're going to want to consider vancomycin. And these are all in your order set. I'm just kind of explaining it to you. The gentamicin is also another good choice. So the vancomycin and gentamicin, once again, a 24-hour dosing for penallergic. If they're GBS negative, once again, the cefoxitin, that 4th generation cephalosporin, and you can just add the Clinda, 900 milligrams every 8 hours. For pyelonephritis, Rocephin is every 24 hours, is a great drug to give for somebody that has pyelonephritis. And an alternative regimen is to give the Amphigen. Now, once again, because you have a fetus inside, you have to consider not doing a 24-hour dosing, but do more of a every 6-hour dosing. For severe penicillin allergy, you can give Astronam 1 gram every 8 hours, but once again, it's really good if you have, it's very narrow in its, what it treats. It only treats like gram-negative or, gram-negative bacteria. So just, you would never want to give it in isolation. Community-acquired pneumonia, these patients are very sick. We're going to want to give lots of different stuff, Rocephin, the 24-hour dosing, azithromycin every 24 hours, and if you suspect MRSA, you're going to want to give vancomycin. And then Astronam, as I said, is ineffective against gram-positive and anaerobic. It is good for gram-negative and used to treat sepsis, and it's good for E. coli. That's E. coli is gram-negative, Enterobacter, Klebsiella. So just know it's kind of narrow, and the dosing is 1 to 2 grams every 8 hours. And when administering IVs, it's not compatible with many other meds. So really check the compatibilities when you're hanging it and fleshing the line in between. Check kidney function. With all the antibiotics, you're going to want to know what the kidney function is. So that's why it's good to get that chem panel when somebody screens positive, so we know their creatinine BUN is. Next slide. 20% of our population, we don't know what they have. So, what do we give when we don't know what their infection is? Well, Zosyn is actually the best antibiotic to give. We give 3.375, and it's if panallergic, you can give the cefepime. However, Zosyn is our go-to. And if we're going to give, we can also give Vanco in addition. Per pharmacy dosing. Always consult your pharmacist, and pharmacy has antibiotic stewardships in their pharmacy department, so you could talk to pharmacy a lot about antibiotic questions. Next slide. The Vanco, I really just want to talk about just it kills gram-positive organism, and I want to go over red man syndrome because red man syndrome, these patients, when we're giving Vanco, when the rate is too high, they actually can get a rash, and they can look like they're having an allergic reaction, but it's called red man syndrome, and it just has to do with the purification process of Vanco. And I'll go over that in the next slide. And it's incompatible with many drugs. You really have to check that IV site, because if you get an extravasation, it can get necrotic, it can get really bad. So you really want to be checking that IV site very diligently when you're running Vanco. Monitor for phlebitis infiltration during the first 5 minutes of infusion, and you're going to monitor this patient very closely for red man syndrome, and of course checking the kidney function. So for Zosyn, once again, that is a great drug to give, and I went over the dosage, but I didn't go over incompatibilities. It's incompatible with lactated ringers, gentamicin, vancomycin, so really use that IV tubing exclusively for your Zosyn due to the multiple drug allergies. And what is red man syndrome, and what should I do? It's a hypersensitivity to the Vanco. Like I said, it had to do with the purification process, often associated with rapid infusion in the first dose. Usually we're always giving it according to what the pharmacy recommends, but every patient, how they react to the medication is different. So if they develop this rash over their chest, and consider that it could be red man syndrome and due to the rate. Like any other drug, you're going to want to stop it, and you're going to want to call the pharmacy and consult your doctor and the pharmacy about what to do when you have this. But I just want to alert you because that it is, I seen it actually just in the last month. Somebody thought it was an allergic reaction. You're going to slow down the infusion. You're going to monitor for hypotension, tachycardia, dizziness, because if the patient's symptomatic, then it's probably not red man syndrome, it's more of an allergic response. You're going to, if the patient develops a rash and itching, slow down the infusion, monitor closely, give Benadryl for the next dose. Just follow what your pharmacy and your doctor tells you to do in those circumstances. Last but not least, I just want to talk about Tamiflu because we're coming into the flu season. It's really important that when we get patients in triage, and if they come in with a fever and we're diagnosing them saying that they have the flu, that we can draw, it's better to draw the influenza A and B cultures, but if the doctor does not want to do that, at most we should be giving the Tamiflu. Tamiflu 75 milligrams BID for 5 days. There's a very low risk to the patient or the fetus. And the thing that is, if it is the flu, the patient will get better. You want to prevent that cascade of events where the patient has the flu and then they cascade into a severe bacterial infection into septic shock. And they go into acute respiratory distress. So Tamiflu, every flu patient should be treated with Tamiflu before going home. Thank you.